All right, everyone have their ophthalmoscope?
Yes.
Good, welcome to our simulation testing, simulation thing here. So what we're going to do, we're going to go over with our models today and kind of go over some normal and abnormal fundi. So, you know, the goal here is that we want every single neurologist to feel more, neurology resident, to feel more comfortable doing the fundoscopy examination and to be able to recognize major abnormalities. Now, we are not going to be ophthalmologists. There's going to be lots of ophthalmological things we're not going to recognize, lots of anomalies we're not going to know, and that's okay, all right? But we're supposed to be able to recognize kind of like major things, okay? Now, our ophthalmoscope, either the regular ophthalmoscope or the regular ophthalmoscope or the panoptic ophthalmoscope. When you turn it on and you see the light, you can turn the aperture to have many different types of lights. So it can be a big circle, medium circle, little circle, a slit, a half moon, something green or something red. Here's the bottom line. You want to use the large circle or the small circle. If the pupil is small and not dilated, use the small circle, all right? Because the idea is you put too much light on them, it's just going to make the pupil constrict more. However, if the pupil is dilated, especially pharmacologically dilated, all right, you want to use the larger light. That's what you want to do, okay? Then you want to make sure your power is about 80%, between 80% and 100%. Some people will say, well, maybe not 100%, because with 100%, it might be too bright and it'll cause the pupil to constrict, okay? Now, if the eye is dilated, that's not an issue, okay? Not an issue. Okay. Now, when we do this, what you want to do is darken the room. You want to darken the room, pull the shades, turn off the light. You want to choose the right size light that we just talked about, the big circle or the small circle. In general, when you're looking at the patient's right eye, you will use your right eye. You're looking at their left eye, you use their left eye. The panoptic can kind of get away with using your right eye for both if you want. But in general, it's right to right, left to left. If the patient has glasses, they got to take them off. If the patient has contacts, they should keep them in. If you have glasses, it's up to you. Yours should probably stay on, okay? Your glasses should probably stay on. Now, this is one of the most important things, is that you look through your ophthalmoscope, look approximately 10 feet away, go ahead, and then focus. Turn your wheel until you see whatever is 5, 10 feet away is in focus. So go ahead and do that.
It's not the hand thing?
Well, you can do that too. I would do it more like 5 feet away. Okay? Just pick a spot someplace far away and just make it relatively in focus. Okay? Or like even like here, like look over here, relatively in focus. You know what I mean? That will take care of the refractive error in your own eye. Okay? All right. Then as I mentioned, you put the power at about 80%. And then on our simulators here, there is the power button at the top, which should be green. Okay? In the back are these buttons that go up and down. You're going to look at the right eye and put the button up to 9. So you tap 1, 2, 3, go up to number 9. Okay? And it'll do the right eye. Okay, you're going at 9. Yep, now you're 6. Nope, I got to go up. Other button. Nope, you're the right eye. Over here. There, go up. There's up and down buttons. Plus, that's down.
Keep going.
Up, 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 up. Good. Number 9. Excellent. Excellent. Okay. Now, you get to turn your ophthalmoscope off because there's actually a light in this thing. Okay? So now, what you're going to do is take the head. Again, you focused in about 10 feet away. You're going to come in at approximately 15 degrees off the midline. You don't come straight in because you remember the optic disc is kind of off towards the nasal side. So you're straight in with the patient. You're about 15 degrees off, and you look at the eyeball, and hopefully you should see kind of a red reflex. It's not really red. It might be orange, red, pink. That means you're getting the retina. And then what you do, you come in closer, 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 go right up to the eye, and then you'll start to see the retina. And when you get there, then you want to slowly turn your dial and make it as sharp as possible. Okay? So go ahead and do that. Okay? Oh, part of this exercise, you have to tell me the truth, which means if you see something or don't see something, you've got to tell me. Okay? Does everyone see the retina yet? And can you see the disc?
Yes.
See the disc?
Not yet.
See the disc?
Yes.
See the disc?
Yes.
Okay. Now, if everyone sees the disc, okay, let's look at the disc. You'll notice it's kind of a circle, right?
Yes.
Do you agree?
Just look
It's
at
a
that.
circle, but if you actually look more closely, it's actually slightly an oval. It's actually slightly taller than it is wider. Does everyone agree?
Yes.
Okay. Then in the disc, if you look in the direct center of the disc, you'll notice it's whiter in the direct center of the disc, right?
Correct.
That's the physiologic cup. What do you think? You see the cup?
Mm-hmm.
Okay, good. That's the physiologic cup. That's where the blood vessels come out. You're going to make a determination approximately how big is the cup compared to the whole disc. Okay? A normal person is about a third the size, maybe up to half the size. Okay, now let's look at the blood vessels that leave the disc. In general, the blood vessels go up and down, but also they really go into 4 quadrants. So they go up and to the left, that's temporal, up and to the right, that's nasal, down and to the left, that's temporal, down and to the down to the left, it's temporal, down to the right is nasal. You generally see the blood vessels kind of go in 4 quadrants. Everybody agree?
Yes.
Everyone agrees. Good.
Mhm.
Now, how do you tell the difference between an artery and a vein? Because they tend to run very close to each other. In general, the veins are bigger. Okay? Most veins are bigger in the body than the arteries. Plus, the arteries are redder because they have venous blood or deoxyagent hemoglobin. So, for instance, if you look right at 6 o'clock, 7 o'clock, you'll see 2 vessels that are going down, a thicker one on top and a thinner one on the bottom. The thicker one, which is redder, is going to be the vein. The thinner one is going to be the artery. Does everyone appreciate that?
Yes.
Okay, good. Now, if you then start to look around the retina and look slightly to the left of the disc, you'll see especially those blood vessels that are going up and over, down and under. And if you look directly in the center, you'll see an area of the retina where the blood vessels are kind of surrounding, which is more pigmented. Do you see that?
Mm-hmm.
All right, that's the macula. Now, if you look closely, the blood vessels come pretty close to it, but they really don't cross the macula because the macula gets a lot of its blood from behind, from actually the choroid. All right? So this is the normal optic fundus. And then as you can see the disc borders are reasonably sharp, especially on the temporal margin. It's very sharp. Okay? You see the cup. You can see the color of the disc, how it's different than the cup. You see the arteries and veins that leave. They go up and up in temporal, up in nasal, down in temporal, down in nasal. And if you look directly in the middle, you'll see the macula, which is pigmented. In general, when you look at the disc, if the person can cooperate, you're going to look at the disc and the arteries, then kind of scan the retina in all 4 quadrants, and then to look at the macula at the end. The easiest way to do it is to say to the patient, look directly at the light. Then they will turn their eyes. The macula is looking directly at you.
Cool.
Okay, that's the easiest way. Okay, good. Okay, now that's the normal retina. So let's take a look at this here. All right, so this is what you just saw a moment ago. So again, here's our disc, which is circular, but actually it's slightly oval, a little bit higher than it is wide. Okay, the margins are very sharp. Okay, are very sharp. The blood vessels leave from the cup in the center, which is white. You're going to make a determination how big is the cup compared to the whole disc. This is an approximate. Okay, it's roughly a third to a half. The blood vessels leave. They go superior and temporal, superior nasal, inferior temporal. You try to figure out, gee, what's the artery, what's the vein? Right here, this is the artery, this is the vein. The artery is thinner, the vein is bigger, the vein is redder. Okay, you're going to try to get a view of the 4 quadrants of the retina if possible, looking for abnormalities that we'll look at in a second. But then the thing in the center that's pigmented, this is the macula where the fovea is, where central vision is. Okay, as you're going to see. Okay, so those are the important things to do. So let's do it again. So focus about 10 feet away. Make sure it's like in focus for you. Then come in at about 15 degrees, see a red reflex or some orange or pink or red, come in, come in, come in, get very close, then slowly turn your wheel one way or the other till it focuses in, and then get as close as possible. Okay? Then when you're there, you want to look at the disc. Notice that it's sharp. Look at the cup. We can see it's white. It's roughly a third of the disc. Look at the blood vessels, the veins and the arteries. Kind of follow them down and over, up and over. And when you're done, look at the macula in the middle. That's what you want to do. Then let's go back to the disc and look at how the arteries and veins leave the disc, especially the big vein at approximately 7 o'clock. You see the big vein at 7 o'clock?
Mm-hmm.
It just runs straight out, right? It just runs straight out. Okay, good. So that is the normal fundus. Okay. Now, I'm going to have you turn to number 10. So go to number 10 here. Okay. So now, this will be the same story. Focus at a distance. And now, come in at 15 degrees. See your orange or red reflex. Come in closer, closer, closer. This is going to be kind of a blow up of the disc. And then focus very closely on the disc. And does everyone now see the disc?
Yes.
Okay. What do you think about the cup size compared to the disc?
Huge.
Very big.
It's much bigger. So the cup to disc ratio is increased. Does everyone agree?
Yes.
Okay. Okay, good. Do you know what finding that is classically seen in? The
Glaucoma.
cup to glaucoma, exactly. Okay, now, glaucoma, why is glaucoma an incredibly important thing to recognize? Right?
The most common treatable cause of blindness.
Exactly. So it's the most common cause of preventable blindness. So you think about your disc being your donut, and here's the hole in the donut. The hole is where the blood vessels come out. You're just going to make a gross approximation of what the ratio is of the cup to the disc. Again, normal is like a third, maybe up to a half. Okay. If you look at a normal disc, so here's the disc, okay, going around this size. Here's the cup. This is kind of a normal cup to disc ratio. However, if you look at this one, this is very similar, what you just saw in your simulator. You say, oh man, that cup is pretty prominent. Okay, it's like this, okay, compared to the whole thing. This is a half. Now, you might say, gee, up to a half might be considered normal, but this you would definitely want the ophthalmologist to measure the interocular pressure. Can glaucoma cause headaches?
Yes.
Sure, absolutely. Now, let's look at this one. Look at this cup to disc ratio, right? This person may have no symptoms, okay? So you'd say, oh my God, look at the cup here. It's this big compared to the disc here, really big. Now, look at this one, same story. Again, the disc is very sharp. Here's the size of the disc, but here's the size of the cup. So this is classically what you see in glaucoma. So even though we're not ophthalmologists, we want to be able to recognize at least markedly large cup to disc ratios. Okay? All right, very good. Now, let's go to number 11. Hit number 11. Okay, same story. Focus about 10 feet away. Okay, now come in at about 15 degrees. You see a red reflex. You get closer, 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 closer. As you get closer, gently turn your wheel and focus in on the retina and see if you can find the disc. Can you see the disc?
Is it weird that I don't have to turn the wheel?
It's not weird. It just means you're in focus.
Okay.
That's fine. Okay? But just focus as best you can.
Okay.
Does everyone see the disc?
Mm-hmm.
Yep.
Good. Now let's look at the veins first. Do you agree the veins are very tortuous?
Indeed.
Absolutely. The veins are engorged and very tortuous. What do you think about the size of the optic cup? It's kind of been obliterated,
Yeah.
right?
Cannot.
It's kind of like filled in. Now, let's look at the borders of the disc. What do you think of the borders? Are they distinct?
Totally blurred.
They're totally blurred. So they're blurred on the left, blurred on the right, blurred up, and blurred down. So this is papilledema, okay? However, one of the most important things about papilledema is that the optic nerve head is elevated or raised. So look at the big vein at exactly 6 o'clock, okay? Notice what it does. It comes out of the disc, it turns, runs down, then turns and runs straight out to show you the disc is elevated. Do you believe that? Look at the big vein and artery at approximately 5 o'clock. Same story. They kind of run up, down, and then out. Do you believe that?
Mm-hmm.
If you look extremely closely at a very small artery at approximately 9 o'clock, it's a small one, same story. It comes up, little bump up, runs down, and then over. Do you believe that?
Yes.
Okay, good. So this is papilledema. Okay, this is papilledema. Okay. Now, papilledema is caused by increased intracranial pressure. All right, period. Because the CSF is in continuity with the sheath of the optic nerve and transmits the pressure to it. Papilledema has no symptoms itself. Now, if you're a very clever medical student, you might pick up an enlarged physiologic blind spot. So you say, oh, you see this, see this. Okay, you know what I mean? But besides that, it has no symptoms itself. Now, if someone has chronic papilledema, yes, it can damage the optic nerve, right? But acute papilledema, they're not going to have any visual symptoms. Most of the times, won't have any visual symptoms. They might have symptoms of their intracranial pressure, though, headache or nausea and vomiting. So what do you see? The retinal veins are congested and tortuous. Often the physiologic cup gets filled, okay? And the disc gets blurred. But here's the thing. It tends to happen first in the superior and inferior margin and the nasal margin. The temporal, which is the easiest to see, that's the last one to go. In addition, the nerve head elevates. That's the big thing, okay? You may have even seen some MRI scans already where they do an MRI scan of the globe with papilledema. You can see the optic nerve and the head is actually sticking into the globe, okay? Then what tends to happen is the big vessels, as they approach the disc, they get obscured in all the edema. It works out the ophthalmologist will grade papilledema on a scale of 0 to 5. 0 means normal. 1 means there is early papilledema with just swelling of the margin of the disc, but superior, inferior, nasal, but not temporal. This is the inverted C. We'll see that in a second. Grade 2 means the entire thing is swollen. Okay? Grade 3, it's swollen and the optic nerve head is elevated. And you're starting to lose some blood vessels as they enter the disc. Number 4, you have loss of some of the major blood vessels as they go to the disc. And 5 is you have total, obscuration of all the blood vessels of the disc. From our point of view, it's not important for us to be able to tell 4 versus 5 or 3 versus 4, but to identify papilledema. Okay, so let's look at this one here. So you look at this and say, oh, doesn't look too bad. Doesn't look too bad. But now let's look more closely, and you'll notice the physiologic cup is a little bit on the small side. Okay, you look at the disc right here, it's pretty sharp right there, right? But it's not so sharp here. It's not so sharp here. It's not so sharp here. Okay, so what this is like the inverted C, right? This is what happens in early papilledema, that the temporal is like the last one to go. However, this is a little bit beyond that, because the important thing here is the optic nerve head is elevated. How do you know it? Look at this vein artery. It runs here, down the hill, out it goes. Okay, here it runs here, down the hill, out it goes. You can appreciate the optic nerve is physically elevated. Okay, that's what makes it. Look at this one, down the hill and physically goes. Okay, that's the really important thing. Now, let's look at this one. Oh, sorry, there's the down the hill thing. This one's grade 3, all right? It's actually now blurred on the temporal side. It's blurred all the way around. And this whole thing is elevating. Look at the blood vessels here. Down the hill, out it goes. Okay? Now, here is grade 3. Oh man, the disc is clearly blurred. Look how it's elevated here. The vein runs down and then out. But you're starting to lose some blood vessels in all the edema. Starting to lose some blood vessels in the edema as it goes through. Here's grade 4. Man, I don't see any cup at all. It's incredibly blurred. The vessels are really engorged and tortuous. And now the major blood vessels, we're just losing them. We're losing them. We still see 1 or 2. And grade 5 is total obscuration. Okay, total obscuration of the disc. Okay, so let's look at this one more time because it's so important. Go 10 feet away, focus in. come in at 15 degrees, come in to get closer, 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 then focus on your disc, and you notice that the veins are engorged and tortuous. You notice the physiologic cup has really been small or squished together. Then you'll notice that all the margins are blurred, up, down, left, and right. But then very importantly, the optic nerve head is elevated, and you can prove that by seeing those veins and arteries run down the optic nerve head and then run out. Okay? Does everybody agree they see that? Okay, good.
What's the stage of this one?
This one's probably 3. This one's probably 3. Yeah. Okay, good. Now let's turn to number 12. Number 12, same story. Let's look at a distance. Coming at 15 degrees. This one has more than one problem, but I want you to come in until you can kind of see the disc and then focus in on the disc. Okay, focus in on the disc. This one, the retina's got some problems. We're not going to look at the retina right now, just the disc. And I'm going to ask you, what do you think about the color of the disc?
It's white.
It's white. Do you see any clear differentiation of the cup versus the disc?
No.
No. This is optic atrophy. Okay? The disc is like this pale moon. Okay? This is optic atrophy. All right? Now, let's go this way. Optic atrophy refers to death of the retinal ganglion nerve axons. We've actually killed off the nerve fibers of the optic nerve. The fundoscopy, it looks like a pale moon, right? This is an end-stage thing that happens to anything that causes optic neuropathy, okay? So it could be toxic, it could be, B12 deficiency, it could be compressive, it could be trauma, but in our business, it's most commonly seen with MS or optic neuritis. Not optic neuritis today, but optic neuritis in the past. So someone said, gee, I had this spell 5 years ago where I lost vision in the eye, I came back over 2 months. You look at the fundi, and boy, that disc is really pale compared to the other one, okay? For the sake of argument, if you have chronic papilledema, that can cause optic atrophy. So here's optic atrophy, where it's like, boy, it just looks like a pale moon. It's like, where does the cup end? Where does the disc start? It's not clear at all. This one's even better. It's this pale moon, okay? It's like the nerve cell layer. You can no longer make it out. Here's another one that's blown up. It's a pale moon, right? It's an end stage from many different things, and we'll see more of those in a second. Okay, let's look at number.
This seems hard to tell apart from like one-to-one.
Sure. So for the
cup
sake of
disc.
argument, glaucoma, could it cause
Yeah.
optic atrophy in the end? Absolutely.
Are there any
Absolutely.
clues to differentiate
Well,
this from?
I think with glaucoma, the cup to disc, you still have to see the physical cup. I mean,
Okay.
there's supposed to be that small layer
Okay.
of nerve tissue. But yeah, end-stage glaucoma causes optic atrophy. Okay, so let's look at number 14. Okay, so turn to 14. Good. Focus 10 feet away. Okay, come in at 15 degrees. Come in, come in, come in, come in. And then focus on the disc. And what do you think of the disc? It's pale. This is optic atrophy again. Now, once you have the disc, follow the blood vessels down at approximately 6, 7 o'clock. Okay, down. You see this big vein, it'll bifurcate. And then you'll see this important finding roughly about 7:30.
Nicking?
That's nicking, exactly. Okay, so the artery is running over the vein, and you see this nicking. Okay, and when do you typically see this?
Hypertension.
Hypertension, exactly. So the optic atrophy is probably from chronic hypertension.
Spread.
You could just about guarantee if you see AV nicking in the retina, the same thing is happening in the kidney, the same thing is happening in the brain. Okay, so that's AV nicking. Okay, let's go to number 15. 15. Okay, and let's focus in the distance. And now let's come in at 15 degrees to get closer, closer, closer. And then focus in.
Oh.
You think it's normal or abnormal?
AB normal.
Okay, it's AB normal. Okay, can you make out where the disc should be?
No.
Yes, well, where it should be.
Do
This
you
should
see
be
any
yes.
margins of the disc?
No.
No margins. The vessels are tortuous. You say, oh my God, this is like really papilledema. I'm not seeing any cup. The disc is totally blurred. The blood vessels are really tortuous.
And if I look at that one vein at 6 o'clock, you say, well, that may run down. However, you see other things. You see all the white spots.
Yes.
Those are cotton wool spots. Those are retinal infarcts. Then, do you see all the hemorrhages right off the disc? And if you follow one out roughly about 9 o'clock, it's about one
Yes.
disc diameter to the left, you'll see this flame-shaped hemorrhage. Everyone see that? If you follow the tortuous vein down at approximately 7 o'clock, 7:30 or so, and go down past its bend, you'll see 3 flame-shaped hemorrhages there. Do you see those?
Yes.
1, 2, 3. Now start to look to the left and look into the retina, and what do you see? You see all these hemorrhages, all these dots and blots. You see them on the below, you see them on the middle, you see them on the top. There are multiple retinal hemorrhages everywhere. Dot and blot, flame-shaped hemorrhages, as well as these cotton wool spots. Does everybody agree? And then, if I tell you, oh, this person's vision is really screwed up, their vision is not normal, would you expect that in papilledema? You wouldn't, actually, you wouldn't. So, actually, what this is sentinel retinal vein occlusion. That's what this is. So, on one hand, you see optic dysedema, like papilledema. All right, you see optic dysedema. However, you see all these cotton wool spots. You see all these hemorrhages and dilated veins, and the patient often loses vision. All right, or their vision's really impaired. So, like, let's look at this one. All right, it's like, oh my God. All right, you can probably guess that this is supposed to be here, but it's been totally obliterated. We see no cup, we see no margins, but we see these cotton wool spots. Okay, then we see flame hemorrhage. Then out here in the retina, we see all these dot and blot hemorrhages. Okay, so when you see something that looks like florid papilledema, but there's cotton wool spots and there's retinal hemorrhages throughout the retina, you want to think about sentinel retinal venous occlusion, especially if they have visual loss, because papilledema doesn't have visual loss. When you think about it in the brain, if you occlude your cerebral sinus, you tend to get venous infarcts, and they tend to be hemorrhagic, right? That's what happens. So here's another one where basically, oh my God, all these hemorrhages throughout the retina, okay? Here's another one, you say, oh my God, where is the disc? Well, we're going to guess it's someplace in here, okay? Totally obliterated, no cup, and just hemorrhages galore, okay? So let's look at this one again, okay? Do 10 feet away, okay? Focus, come in. Oh, my thing just went out again. That was number 15. And convince yourself that the disc is really, really blurred. You don't see any cup at all. The veins are really tortuous. But the big difference here is there's all these cotton wool spots. There's all these retinal hemorrhages. And the hemorrhages are flame-shaped, or they're the dot and blot hemorrhages. Everybody agree?
Mm-hmm.
Good. Okay, good. Now, let's go to number 22, which is a really important one. You don't see it too often, but it's super important. So 22, okay, do 10 feet away, focus, come in at 15 degrees. This is going to be a blow-up. You're not going to see the disc. Don't worry about that. You're just going to see part of the retina, and you're going to see an abnormality dead center in the middle. And it's a boat. It's a red boat. Everyone agree?
Mm-hmm.
Okay, so this is a retinal hemorrhage. That's a red boat. What do you think this is caused by?
Subhyoid.
This is a subhyoid hemorrhage caused by?
SAH.
Exactly, right. That's exactly right. Okay, so let's go back. So this is a boat hemorrhage. So the story is all the globe is filled by the vitreous. The back of the vitreous is this hyoid membrane, which is very thin, which is right on top of the retina. If you get a sudden change in intracranial pressure, you will often bleed there. All right. So here's a gigantic one, and you kind of get this hematocrit level. You get the layering of the blood cells. So this boat-shaped hemorrhage, actually. This is really pathognomonic for sudden increased intracranial pressure. So you can have it in trauma, obviously, but the most common place is actually with an aneurysm bleeding. So if you had a patient who said, I'm just having dinner, oh my God, I had this terrible headache, it came in all of a sudden, and they came in and their exam was normal. except they had this terrible headache. Say it's a really bad migraine headache, and you saw a boat hemorrhage. That is subarachnoid hemorrhage, period. Okay? That's what's so important about this. You don't see it in every case, obviously. So it's one of these things where if you do see it, it's super important to recognize. Okay? The boat hemorrhage. Okay, good. Okay. Fine, this one. Let's go back to number 16. Okay, 16. And we'll focus at a distance. And we're going to come in. This one, you're not going to see the disc. This is actually a blow-up. Come in till you start to see the retinal and some vessels, and then focus in. Now, what do you think about the color of the retina?
Pale.
It's really pale. But do you see this bright red dot in the middle?
Mm-hmm.
Okay, what do you think this is going to be? Good. So this is sentinel retinal artery occlusion. So the whole disc gets pale because there's no blood flow coming to it. Okay? No blood flow coming to it. Let me just get this one here. Okay. No blood flow coming to it. Oops, sorry. So what you see is a very pale fundus with this cherry red spot in the macula. Why is the macula cherry red? Because it gets its blood supply from behind, from the posterior ciliary arteries. Okay, posterior ciliary arteries. What do you think happens to a person's vision when they block their sentinel retinal artery? It's totally lost. It's devastating. So if you think about the vascular anatomy here, so it's the carotid artery, the ophthalmic artery, then the sentinel retinal artery. So typically when this occludes, it's a stroke. So the most common thing is an embolus. Embolus from the carotid, embolus from the heart. Could you have local atherosclerotic disease of it? Sure, I guess that's possible, but most likely it's an embolus. However, it can also be a local vasculopathy. It can, and the one we worry about the most is giant cell arteritis. So in the right age group, or in the right clinical setting, somebody could have, a sentinel retinal artery occlusion from temporal arteritis. Now, this cherry red spot may take a few hours to develop. So when you first look at it, you just may see a totally pale retina. It's like, oh, I don't really have a good red reflex here. It's really pale. But a few hours, this develops. So in case someone came in like right away, it may not be obvious. But if you ever see this is a classic pattern. And it kind of makes sense. So if you think about the artery occlusion and the venous occlusion is totally different. The artery, everything is pale. The venous, all the blood backs up, and it's like a big mess. Everything's swollen, everything's torturous. You have all these retinal hemorrhages. Okay, all these
They're
retinal
both
hemorrhages.
painless.
They're both generally painless, yeah. Okay, now let's look at number 23. Okay, 23. Focus in about 10 feet away. Come in at 15 degrees. Start to see some red reflex. Get closer, then gently tune your thing. And can you see a disc here?
Yes.
What do you think about the color of the disc? It's a little pale. Man, it's pale, a little pale. But then it's surrounded by, oh my God, hemorrhage, right? These are multiple retinal hemorrhages. Okay, multiple retinal hemorrhages. So, let's go back and talk about this. So retinal hemorrhages, people talk about dot and blot hemorrhages. This classically occurs by the capillaries rupturing, classically seen in diabetes. The flame-shaped hemorrhages, classically seen in hypertension, although it can be seen in other things. And then the boat hemorrhages we just talked about. So here's one who has multiple retinal hemorrhages. All these are dot and blot all over. However, here is like a flame-shaped hemorrhage. Okay, and then here's our boat hemorrhage. So we should be able to recognize major hemorrhages. How about that? All right, the dot and blot, flame, or a boat-shaped hemorrhage.
So why is this all of them? Is this
This
a
one's probably,
venous?
this is probably trauma, actually. This is probably trauma. All right, now let's go to number 3. Number 3. So go down to number 3, and there's the 3. Okay, go to 3. Focus in at a distance, about 10 feet away. Come in at 15 degrees, come closer. And then when you get closer, you'll get near the disc. Can everyone see the disc? What do you think of the color of the disc? It's pale. It's optic atrophy again. Okay. The whole retina is a little pale too. Do you agree? Now let's look at the blood vessels at 7 o'clock off the disc. How would you characterize those blood vessels? They're thin, delicate, and multiple, right? It's like a spider web, right? Do you agree with that? So this is neovascularization. This is what happens in diabetic proliferative retinopathy. Now this will be more of an issue, obviously, for our ophthalmologists, but this is something that happens in diabetes. You can imagine how easy it would be for these to burst, right? They're so delicate. And this person has optic atrophy as well. Okay, so that's what happens in diabetes. Okay, let's go to number 30. Okay, focus in 10 feet away, and then why don't you come in till you see the red reflex. Okay, the red reflex, and then focus in on your disc or your retina. Oh, I can see the disc pretty well. Okay, but then in the retina, is there a problem?
Yeah.
There is a problem. Yeah, it's probably near the macula, exactly. Okay, does everyone see the quote lesion?
Yep.
Everyone see the lesion. Would you agree that it's relatively oval?
Yep.
Would you agree it's relatively demarcated? Good. And you see in the center there's a lot of pigment right around the outside, kind of. This kind of dark pigment, and the middle is white. Do you believe that this is a scar? This is kind of a scar-like thing to you? Okay. Well, it works out. These all look the same. Okay, these all look the same. And this is a toxoscar.
Whoa.
All the toxoscars in the retina look the same. Now, when you do pediatric neurology, you'll see what toxo looks like in the brain. But many times you can see in the retina too. It tends to be circular or oval, well demarcated, tends to have a lot of pigment on outside. The vision loss depends on where it is. Obviously, central vision is a big problem, okay, but it may be totally asymptomatic. So this is what a toxoscar looks like.
Whoa.
Okay.
So you're saying it could end up in any spot?
Sure,
but
any
it will
spot.
always
What if
have
it's,
that,
what if it's
that
down here?
appearance.
Exactly.
Okay.
If you Google toxoplasmosa retina, go to the images, they all look the same.
Oh.
They all look the same. Okay? That's kind of a neat thing for pediatric neurology.
What about the optic?
Huh?
Is atrophy?
Or
Or can be or cannot?
it all depends. It all depends, yeah. Okay, let's look at number 27. Now, this is going to be a blow-up view. So let's look at a distance. Come in, closer, 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 and then let's focus and ask yourself, do you see a big blue-gray blob? But off to the left of the blue-gray blob, do you see the retina? Okay, now the blue-gray blob, do you agree it's relatively demarcated? Do you agree there's kind of some pigment around the outside, especially kind of lower? And can you convince yourself it's really not that flat? It may be slightly elevated off the disc, off the retina. Can you kind of appreciate that maybe it's elevated? That's harder. Okay, so what this is a melanoma. All right. Now we're not going to make this diagnosis. Okay. We're going to call the ophthalmologist. But if you see this pigmented thing that you see gray, blue, maybe dark, okay, especially if it looks like it's raised off the retina, that's what we worry about if it's a melanoma. Okay. Now contrast that to number 29. Okay, 29, and focus 10 feet away. Come in, come in, come in, come in, and then focus again. And now it's kind of the opposite. You still see a blue-gray blob, right? But now you see the retina off to the right. And ask yourself, this blue-gray blob, are the margins distinct? Not as distinct. If you go into the middle of it, you can see some white dots. That's drusen. And you can see some whitish area above it, like some atrophy. And then if you look closely, it looks flatter than the last one. Do you believe that kind of?
Yeah.
It's not as obvious that it's raised. Okay, so this is a nevus. So this is the difference between a mole and a melanoma. All right, so they're both pigmented. They're both pigmented. This blue-gray pigmented. The nevus tends to be flatter. Okay, tends to have margins that are not as well defined, and tends to have some atrophy in the middle. Now, you and I are not going to make the determination of a nevus versus a melanoma. We're going to call the ophthalmologist, right? But we should be able to recognize it, right? Do you know how they treat ocular melanoma? They enucleate the eye. Yeah, exactly. Now, one I don't have a picture of, which I do want to go over, and that is this, and that's the Hollenhorst plaque. The Hollenhorst plaque is often when you have carotid disease, although to be fair, it could be aortic disease, and you break off a plaque, not a clot, but a plaque, and if the plaque has cholesterol in it, it can go up and get stuck in the retina, and it often gets stuck at a branch point. It'll appear extremely yellow. It's so refractile. So this is what a Hollenhorst plaque looks like. So here it is, it's like here's the artery going out, and boom, it's stuck at the bifurcation. Okay, stuck at the bifurcation. Now, why is this one so important? Because let's say the patient comes to you with a spell and say, last week I had this thing where I just couldn't get my words out. I knew what I wanted to say, I just couldn't come up with the word I wanted to say, and it lasted like 5 minutes and went away. Their exam's totally normal. But you look in their eye and you see this. That makes you think, what? They must have carotid disease. This really was a TIA. Okay? All right, so that's why it's so important. Now, one thing we missed earlier on with the normal retina is that sometimes you'll look in the retina and you won't see the disc. You'll just see the retina and blood vessels. Like, where the heck is the disc? Here's the easy way. Blood vessels bifurcate. It goes and bifurcates. Now, it bifurcates, it makes a V. So if you don't see the disc, find the V and follow the point. So you say in this one, where do you think the disc is? Is it here, 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 here? Cool. It's down here, right? Here's the V. Down it goes. Okay? Okay. Here's another one, Hollenhorst plaque. You say, oh, it looks pretty good, looks pretty good. Oh, there's this one like bright yellow spot. And you look closely, and here's this little artery, and it's bifurcating right there, and it's stuck right there. So that could be the key to your case for the person who had the funny spell. Okay, who had the funny spell. Okay. Now, the thing about this fundoscopy, does everybody have eye drops? You have eye drops?
I never picked up my eye drops.
Oh,
in violation.
Okay, the last ones. Okay, here you go.
Thank you.
So here's the thing. As you know, we have to do the ophthalmologic examination for every neurological, new patient, be it consult or new patient. We have to do it to be good doctors. We have to do it to get reimbursement. We have to do it so we don't lose our license or get fined or go to jail. Okay, all right. So it's really, really important. It's really, really important. Now, are there some people that you're not going to be able to see the disc? Sure, they have blepharospasm, they have bad cataracts, they can't cooperate, their eyes are so incredibly myotic you can't see it. That's fine, just document it. Ophthalmologic examination, not testable secondary to blepharospasm, not testable secondary to meiosis, not testable secondary to cannot cooperate. That's fine, okay? That's totally fine. Just put that down, okay? However, the other people, you really want to look at their fundus because after you do a couple hundred, okay, it gets easier and easier and easier. And the goal is very simple. The goal is, can I see the disc? Is it sharp? Is it elevated? Can I see the cup? How big is it? All right. Can I see the blood vessels? Any major problem? Cotton wool spots, hemorrhages, okay, things like that. A gigantic toxoscar, a gigantic blue-gray blob, okay? That's what you want to do. Now, are there going to be lots of ophthalmological things that are normal variants that we're not going to get, we're not going to recognize? That's fine, and we'll call the ophthalmologist. So you look at some weird thing, you go, I don't know what the hell that is, and the ophthalmologist says, oh, it's a tilted disc. You know what I mean? The optic nerve is coming in and it's tilted. Okay, fine. There's all types of weird anomalies. But these major things you want to be able to recognize. Now, you want to use your eye drops and dilate the eyes because especially you'll get such a better view. It's like, as you know, it's night and day. If you dilate the eyes on an inpatient, please leave a note on the bed. Patient's eyes were dilated. It's 8 p.m. by neurology, so people don't freak out. The nurses walk in and it's like, oh my God, the pupils are blown.
Call a bat.
All right, call it back. The pupils are blown. Now, if the person's totally wide awake, that type of thing. So don't ever dilate one eye, please. That'd be really asking for it. You could do that, don't get me wrong, but you got to write it down. Okay, write it down. When would you not dilate the eyes? It's really under the situation where you can't afford to lose the pupillary reflex. So it's like trauma. Someone comes in and they're like in coma. Okay, but their pupils react. You need that sign to follow. Somebody has a big intercerebral hemorrhage. Somebody has a cerebellar stroke and you're worried of them occluding the fourth ventricle and getting acute hydrocephalus. You don't want to lose the pupillary side. Okay, so in those situations where you think there's a chance this person, could herniate and you need the pupillary sign, yeah, I agree, you would not do it. Okay? But the person who's we're evaluating for headache. Do you ever get evaluations on the general service for headache? Does that ever happen? That happens once in a while, right? That happens once in a while. Okay? You know what I mean? This is super important. This is super important. So you go to a MAC house and the person's got the pregnant woman has a headache, go ahead and just put it one drop in. And what you do is you look at the pupil reactivity, okay, for the eye movements, put in one drop, do the rest of your exam, and then come back and look at the fundi at the end, 10 minutes later. And it's great. Okay, it's great. All right? Then what you want to do is share this with other people. So like when nobody was on service last time. So we had a lady who had pseudotumor cerebri, right? So she had florid papilledema. So our team, we dilated her eyes, okay? And we had all 11 members of our team look at her eyes, okay? But it's that's what we got to do, right? I mean, I say, oh, that's too bad for her. But it's this is a university hospital. It's a teaching hospital. It's super important everyone recognize papilledema, okay? Because this is my view, before we did this, this is my view of ophthalmological training in the United States, okay? The attending would look in and say, yeah, I think the nasal margin's a little bit blurred. Yeah, it's definitely a little bit blurred. Here, take a look, okay? And the resident would take a look and say, do you see it? Do you see it? Do you see it? And you go, oh, yeah, no, I see it, okay? And you're not seeing anything. But you kind of feel compelled. You can't say, oh, no, I don't see it. You know what I mean? That's what happens. It's ridiculous, okay? It's ridiculous, okay? So, you have to have an ophthalmoscope. It's got to work. It's got to be charged, okay? It has to work. But now our program, I hope we have I think we've optimized this as much as humanly possible. Everyone's got their drops, okay? Everyone's got their drops. Everybody knows about the documentation stuff, right? Everyone knows about that documentation. We've done the videos. We've done the simulation. It's because now you got the drops. The last thing is the simulators are going to stay here in this office. You can come anytime and borrow it for as long as you want. It's totally fine. Please do it. Every box has a booklet in it that says what each one of the findings shows. Okay? Each of the findings shows. Okay? If you wanted to test yourself for fun or with your friends, you can do that because it's actually very clever on the back. It works out. It's very clever on the back. Let me turn this back on. So let's say, oh, Joe or Deepak, I want you to do this, and I flip this. Okay, so you can't see what the number is. Okay, if you want to test yourself, you do things like that. Okay, you do things like that. Okay, just so you know, so they're here for you guys to use. Okay, for you guys to use. Okay, with that, that's a wrap. Okay.
Thank you so much.
Okay.
Thank you very much.
All right.
Thank you.
My problem is I always see the red reflex, and then I keep going in, and it just everything's blurry.
Everything's blurred, yeah.
What
But
am
again,
I doing wrong?
Well, first of all, definitely focus at a distance.
Yeah.
That's really key because
I have LASIK, so
that'll take care of your refractive error. Okay.
yeah.
All right. Number two is that once you get pretty close, then you slowly turn the dial one way or the other and pick something you can focus on, be it a blood vessel or the disc or something. Listen, it's like every skill, it just takes practice. So if you have to look at the first 50, and you don't see it so clearly, say la vie. But then at 51, it gets better. You know what I mean? That's what I think it is.
Yeah, you never know when it's finally going to include.
How many medical students can't elicit a freaking reflex at the ankles? Okay, I mean seriously. All right, I mean seriously. I mean neurology residents can't do it either. Okay, sometimes it kind of bugs me. All right, just so you know. Right? It just takes practice. It just takes practice. But it's going to do. Because then, when you get reasonably good at it, then what happens is the pupils are small. Well, then you get a quick look, and you can say, okay, fine. The disc is at least the disc is sharp. Okay, there's not papilledema. The disc is sharp and it's not raised. Okay, it's not papilledema. All right, all right. You know, but my big thing is we don't want to miss anything that's like really obvious. How about that? You don't want to miss that person with glaucoma. Right. Right. You know what I mean? That's right. Or the boat hemorrhage. You don't want to miss that. You know.
And it's an ACGME milestone.
You don't want to miss the boat.
It's an ACGME milestone, exactly. Right. Then the billing thing. You have a bat. Person comes in. Oh my God! You do all this work. They go to angio. Blah 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 blah. You write all your stuff down. And all these scores. Blah blah blah. If you don't have the ophthalmologic examination there, right? This should be a level 5 consult. You should get paid like $300 for it. But if you don't have the ophthalmologic exam documented, you can't bill level 5. You can't bill level 4. You bill level 3. So instead of collecting $300, you collect $80. And I'm not kidding, okay? Because some coder someplace in your office or in the hospital is going to say, oh, no, you can do that. No, it's a level 3, $80. So like you've given away, $200 because you didn't document the ophthalmologic examination. It's ridiculous, right? You don't want to do that.